Welcome back, everyone. Last time I checked, I'm still Dr. Rybinnik. Venous strokes are confusing? Venography studies got you down? Your attendings are making anticoagulation jokes and you don't get them? Well, today is your lucky day. Let's learn to recognize and manage acute cerebral venous thrombosis. This video is rated R for restricted due to clinical uncertainty, complex language, and low to moderate quality of evidence. Medical students require accompanying resident or attending guardian. I have no relevant financial disclosures. The case featured in this talk was modified slightly for teaching purposes. The final disclaimer is that this is a rare disease, which means low quality of evidence, so take everything I say with a grain of salt and a dash of seasoning. Our objectives for this talk are to introduce a case, to discuss 4 major clinical presentations of cerebral venous thrombosis, to review the 2 major diagnostic modalities and hopefully remember the 9 radiographic diagnostic signs, to understand the medical and surgical treatments for this disease, to summarize long-term treatments and outcomes, and to conclude with a tidy algorithm. So let's start with a case. When a headache is more than just a headache. This is a young 19-year-old woman who was previously healthy. She has no history of headaches. Her only medication is a combined oral contraceptive containing norgestimate and ethinyl estradiol. There's a family history of thromboembolism. Her uncle was reportedly diagnosed with antithrombin 3 deficiency when he developed multiple pulmonary emboli. Over the past week, she developed progressive holocephalic headache, which was preceded by a viral upper respiratory tract infection. The headache became intractable, and over-the-counter analgesic provided minimal relief. Over the past 2 days, she started developing nausea and increasing lethargy, and noted intermittent dysarthria and left-hand tremor. All these symptoms brought her to the emergency department. Her vital signs were normal. There was no fever, and her body mass index, or BMI, was within the normal range. She was somnolent, but easily arousable to voice, and oriented when awake. There was very mild anisocoriae, with the right pupil smaller than the left, but the chronicity of this finding was unclear. There was no papilledema. Otherwise, her neurological examination was non-focal, and meningeal signs were absent. So, in our 19-year-old woman with combined oral contraceptive use and family history of thromboembolism, who developed subacute progressive headaches and lethargy, what is the differential diagnosis? Well, this is a cerebral venous thrombosis talk, so that's probably on the differential. Other disorders that present with signs and symptoms of elevated intracranial pressure are hydrocephalus, intracranial hemorrhage, mainly subarachnoid and intraventricular hemorrhage, and aseptic meningitis. The other disorders that can present with acute headache are reversible cerebral vasoconstriction syndrome and posterior reversible encephalopathy, or PRES. Oh, that reminds me, speaking of clinical presentation, let's review the symptoms of cerebral venous thrombosis. Cerebral venous sinus thrombosis is a disease of the young. Young women, to be precise. The female-to-male ratio is 3:1, and the mean age at presentation is 33. Only 8% of patients aged 65 and over develop thrombosis, and in that age group, vigilance and encephalopathy are more common than headache. Speaking of headache, it is the most common presenting symptom in cerebral venous thrombosis. This is a trend across many studies, including this VENOS study out of Turkey, the largest recent mostly retrospective multicenter cohort. This study actually included over 1,100 patients. But headache is rarely the only finding. It usually comes with signs and symptoms of elevated intracranial pressure, seizures, focal neurological deficits, and cranial nerve palsies. To elaborate, cerebral venous sinus thrombosis really presents as 4 distinct entities. Headache with or without symptoms of intracranial hypertension, the most common presentation. Focal syndrome with neurological deficits and perhaps seizures. diffuse encephalopathy or coma, and cranial neuropathies and painful ophthalmoplegia, especially with transverse sigmoid and cavernous sinus thrombosis. Why is this? You heard of cerebral arterial territories, right? Middle cerebral, anterior cerebral, posterior cerebral. Well, there are also venous vascular territories in the brain, but they're much more variable. I'll point out a few of these overlaid on axial MRI slices. The left side illustrates vein territories, and the right side shows the territory of the nearest draining venous sinus. Superior sagittal sinus and the cortical veins drain the rostral and lateral brain. The largest vein is the superior anastomotic vein, also called the vein of Traillard. The way to remember this is the mnemonic Traillard is top, Traillard, top. Isolated thrombosis of the vein of Traillard is unusual, but can cause frontoparietal edema, which will result in focal deficits related to those brain areas. And when cortex is involved, seizures may follow. Staying laterally, all around the brain is the domain of the superior sagittal sinus. Depending on the study, the superior sagittal sinus and the transverse sinus are battling it out for the title of the most commonly thrombosed sinus. Anyway, let's just call it a tie. Both are thrombosed frequently enough. Superior sagittal sinus thrombosis usually presents with intracranial hypertension from diffuse brain edema, focal symptoms, aphasia, and seizures from venous infarcts. And now the deep venous system comes into view, in blue. We're talking about the straight sinus and the deep draining veins, vein of Galen and the basal vein of Rosenthal. Thrombosis of the deep system causes thalamic edema and impairment of reticular activating system. So it's not so surprising that these patients present with decreased level of arousal. Motor deficits may be bilateral or fluctuating and alternating, one side then the other. This probably happens because of the edema in the motor tracts in the internal capsule and the midbrain. Again, I'm being deliberately vague here since the anatomy involved will dictate the deficits, and anatomical distribution is less precise with venous thrombosis. Inferior temporal lobes are drained by the inferior vein of Labbe and the transverse sinus. Another mnemonic for you, Traillard is top, but Labbe is low. As we discussed before, transverse sinus thrombosis is common. It usually presents with isolated headache, unless it causes a venous infarction. And the venous infarction, because of thrombosis of the dominant transverse sinus in the vein of Labbe, may cause aphasia. Any venous infarction can also cause a seizure. What's less common are cranial nerve palsies. Transverse sinus actually drains multiple upper cranial nerves. Transverse sinus also drains the cerebellum, so extensive thrombosis may cause cerebellar signs and ataxia. At the base of the skull, sigmoid sinus drains the lower brainstem, so you can expect multiple lower cranial neuropathies. Oh, and speaking of cranial neuropathies, the other entity that can cause multiple cranial neuropathies, specifically the nerves responsible for eye control, is cavernous sinus thrombosis. You'll see oculomotor palsies, V1, V2 distribution sensory loss, and orbital pain, chemosis, and proptosis. The frequency of thrombosis in various sinuses varies from study to study, but one thing is clear. More than one sinus is thrombosed in over half the patients, so the clinical picture may actually be complex. That being said, in our 19-year-old woman with subacute progressive headaches and lethargy, if venous sinus thrombosis is suspected, which sinus is likely thrombosed? More than one sinus is likely involved. Okay, that was a bit of a trick question, but considering her lethargy, straight sinus and the deep draining system is probably involved. What imaging studies will help confirm the diagnosis? Well, guess what? That question brings us to the discussion of the diagnostic studies. Diagnosis relies heavily on the CT and MRI-based studies, so it makes sense to spend some time reviewing imaging signs. Let's look at examples of non-contrast head CT first. Since this talk is rated R, I'm assuming that you have some familiarity with the basic imaging modalities and anatomy. If you need a refresher, please watch the brain imaging crash course on this channel. These are axial head CT slices from 2 different patients. What's the abnormality? Pause the video if you need to. That's right, the transverse sinuses look hyperdense, suggestive of acute thrombosis. This is referred to as the cord sign. This sign may persist for up to 2 weeks, after which thrombosed sinus becomes isodense to the brain parenchyma. This is a coronal non-contrast head CT. What's abnormal here? Right again, 2 cord signs, one correlating with a thrombosed superior sagittal sinus and the other with thrombosed transverse sinus. The specificity of this sign is excellent. We're talking over 90%, but the sensitivity leaves much to be desired. Only 2/3 of patients with thrombosis have a cord sign on the initial CT. So the presence of a cord sign helps, but absence really doesn't. Next challenge. Identify 3 abnormalities on this CT slice. You're an expert in cord signs, so I'm sure you've spotted this one. 1 down, 2 more to go. You probably noticed the hypodensity corresponding to a venous infarction in the left frontoparietal lobe. The last sign is more subtle. There is a hyperdensity in the sulci corresponding to subarachnoid hemorrhage. Subarachnoid hemorrhage and venous infarctions are more common than the cord sign. So here are 2 more examples. The image on the left shows a large right frontal venous infarction with hemorrhagic transformation. Which sinus is likely thrombosed to cause this type of infarction? Superior sagittal sinus. What are the abnormalities in the image on the right? Yep, the subcortical structures are hypodense, with some hyperdensities corresponding to hemorrhage. This venous infarction is caused by the thrombosis of the straight sinus in the deep venous system. So, how well does a non-contrast head CT perform for the diagnosis of cerebral venous thrombosis? It turns out, meh. That's a technical term. Imagine you have 100 CVT patients. On average, head CT will pick up direct and indirect signs of CVT in just over half. For the aspiring emergency medicine physicians listening to this talk, non-contrast head CT may miss up to 60% of these patients, so don't be lulled into a false sense of security if the head CT is negative. But say you do find abnormalities that we discussed. Overall, they're highly specific. A positive CT is much more helpful than a negative one. So how do we increase the sensitivity? Add contrast. And that brings us to a discussion of CT venography. By the way, CT venogram has more in common with CT angiogram than with a CT with contrast, because of the timing of the scan with respect to contrast injection. So it takes a proper order and an experienced tech to produce a good study. This is a sagittal CTV, and the visualized sinuses are labeled. What's missing? Yes, the anterior part of the superior sagittal sinus is missing. It's not opacified with contrast like it's supposed to be. You can see the same finding in the axial view. This is a slice from very high up in the brain. I bet when you review head CT yourself, you don't pay as much attention to these high slices. Well, you really should. You might be surprised. This is the coronal image from the same patient. Can you identify the non-opacified sinus? Here it is. Looking at the same CTV in multiple planes is very helpful. Okay, the training wheels are off. There are no labels to help you now. What's the abnormality? Yes, this is another example of superior sagittal sinus thrombosis. And what about this example? Where's the straight sinus and the deep draining veins? Again, non-opacified and therefore thrombosed. Okay, one more example. Identify the abnormality. How about now? Is that better? there is non-opacification of the confluence of sinuses. This is so-called empty delta sign. Thrombosis of the confluence of sinuses is relatively rare and present in up to 1/3. So, does adding a CT venography study actually help? You know what I'm about to say next, right? Of course it does. Adding CT venography to a non-contrast head CT boosts the sensitivity over 80%. The specificity of the CTV alone, though, is worse than a non-contrast head CT. Why? Well, CTV has a tough time distinguishing thrombosis from anatomic variants, like atretic or hypoplastic sinuses, congenital asymmetry, and arachnoid granulations. But what about MRI-based studies? MR venography with gadolinium nicely isolates the sinuses and cortical veins. Here's a maximal intensity projection with the patient facing away from you. What's missing? That's right, the right transverse and sigmoid sinuses and the jugular vein. What about this example? Where's the straight sinus and the deep draining veins? And finally, the anterior part of the superior sagittal sinus is missing here. Interpretation of the MRV is also susceptible to anatomical variants, but what really gives MRV its superior sensitivity and specificity is the concurrent brain MRI. As blood ages, the T1 and T2 signal changes. Let me illustrate it with an example of intraparenchymal hematoma. In the early hours, hemoglobin becomes oxidized and T2 signal slowly brightens. Over the first several days, as the oxyhemoglobin is converted to deoxyhemoglobin, T2 signal becomes hypointense. So in these early stages, it is difficult to diagnose thrombosis, considering that T2 may be isointense or look dark like a normal flow void corresponding to the venous sinus. But in the early subacute phase, methemoglobin, which is paramagnetic, creates a bright signal on T1, which is very helpful. And in the late subacute phase, both T1 and T2 are hyperintense due to extracellular methemoglobin. I mean methemoglobin outside of red blood cells. You can torture yourself with mnemonics memorizing every stage of hemorrhage, or you can just remember that T1 and T2 sequences catch thrombosis with hyperintense signal within about 3 to 14 days from onset. These time cutoffs are not very precise. Evolution of blood signal on MRI is a dynamic process, so take that into account. It could easily be 5 to 15 days. As luck would have it, 85% of patients with cerebral venous thrombosis present within this time period, 5 to 15 days. Thank your favorite deity for small favors. Let's see how this works in practice. T2 axial cut. Normal flow void corresponding to the right transverse sinus is hypointense. Look at the left transverse sinus. It is brightened. We've lost that flow void. This patient presented over a week after symptom onset. These are sagittal and axial T1 sequences without contrast from two different patients. What jumps out at you? Yep, sinuses are hyperintense. So we're dealing with methemoglobin in the early or late subacute stage. T1 is extremely helpful in this stage. I check my MRV against T1. If a sinus is missing on MRV, is it hypoplastic? Well, if it's bright on T1, it's thrombosed. Here's another example. Two axial T1 cuts from the same patient. What's the abnormality? Right transverse and right sigmoid sinuses are hyperintense. Again, methemoglobin is creating this bright signal, so this thrombus is approximately 3 to 14 days old. As I mentioned before, evolution of a thrombus on T1 and T2 is a dynamic process. As the signal transitions from dark to light or vice versa, especially in the acute or deoxyhemoglobin and early subacute or methemoglobin stages, you can be fooled. So we need another MRI sequence to help us. Gradient recalled echo, or GRE. Note the so-called blooming susceptibility or low signal, dark signal, which the thrombosed blood creates in the patient's right transverse sinus. Thrombosed cortical veins are also clearly visible, and GRE is particularly useful in imaging these. MRI is also excellent at showing sequelae of venous sinus thrombosis, like venous infarctions. How do I know these are venous infarctions? For one, the lesions cross arterial vascular territories. The lesions are bilateral. And most importantly, the vasogenic edema builds up at the gray-white junction, initially sparing the cortex. By the way, on the image on the right with bilateral venous infarctions, which sinus is likely thrombosed? Correct, the superior sagittal sinus. Well, that was a lot of information, so let's summarize. Non-contrast head CT and contrast-enhanced CT venography are rapid, so they're generally suitable in an emergency, especially with non-cooperative patients. CT venography images the sinus wall, which can help differentiate thrombus from hypoplasia, but brain parenchyma and thrombus are better visualized on MRI. And CT has potentially harmful radiation and contrast. Brain MRI and MR venogram with gadolinium are slower, but potentially more accurate, and potentially safer. MRI requires patient cooperation to avoid motion artifacts, and may be contraindicated in patients with body metal, like medical devices. When reviewing CT-based studies, you're looking for cord sign or hyperdense sinus, vasogenic edema and hemorrhage of venous infarction, empty delta sign, and general non-opacification of a sinus. MRI-based studies will show hyperintense thrombus on T1 in the subacute or methemoglobin stage. Thrombus will create a susceptibility or darkness and so-called blooming artifact on gradient recalled echo. Vasogenic edema from venous infarction will be located at the gray-white junction and will be hyperintense on flare in T2. In the late subacute or extracellular hemoglobin stage, T2 will slowly brighten, and a normally dark flow void corresponding to a sinus will disappear. And of course, the sinus will be absent on venography. Well, that was a long detour, but couldn't be helped. You need to know how to read CTs and MRIs in these patients. But let's get back to our 19-year-old patient who has subacute progressive headaches and lethargy. Remember that deep venous system or multisinus thrombosis is suspected. Who wants to see our patient's imaging? Not so fast. You have to tell me which studies to get first. What studies will confirm the diagnosis in our case? She's in the emergency department, so we started with a non-contrast head CT. What's the abnormality? Or better yet, what is the name of this radiographic sign? Pause the video if you need to. Yes, the straight sinus is hyperdense, so-called cord sign. Deep draining veins are also hyperdense. CT was followed by CT venography with contrast. What is the abnormality here? That's right, the straight sinus and deep draining veins are not opacified. CTV was followed by a confirmatory MRV and brain MRI. You've seen this image earlier. Straight sinus and the deep draining veins are absent. Here are the three representative MRI sequences: coronal T1 with contrast, axial GRE, and axial flare. Identify the abnormalities. There's non-opacification of the confluence of sinuses. If this were a CTV, this sign would be called empty delta. Susceptibility or dark signal on GRE corresponds to the thrombosed venous system. And finally, flare hyperintensity between the thalami corresponds to late subacute thrombosis, extracellular methemoglobin stage. Our patient presented about a week after symptom onset, so the timing fits. There's one more diagnostic test we should discuss, and that is domain dimer, or D-dimer for short. It's a fragment produced by fibrin degradation. Most of the time, D-dimer has excellent sensitivity and specificity, but it really shines with a remarkable negative predictive value, where a D-dimer of less than 210 essentially excludes cerebral venous thrombosis, at least according to Kaczynski. The caveat is that patients presenting with isolated headache or prolonged duration of symptoms, more than a week or so, have significantly higher false negative D-dimer tests. So, considering wide availability of excellent imaging, we rarely use D-dimer to make the diagnosis or rule out cerebral venous thrombosis. Where I feel it is more useful is in gauging efficacy of treatment. Literature states that D-dimer correlates with clot burden. So if you start treatment on day 1, you will see a nice downward trend signaling decreasing clot burden. This is an example of one of my own patients. In our patient, thrombosis of the straight sinus and deep draining veins was confirmed. And there was no evidence of venous infarction, we just saw the imaging. D-dimer was also done and was elevated at 510 nanograms per deciliter. What is the next best step in the management? Time to treat. In general, once cerebral venous thrombosis is diagnosed, the goal becomes preventing secondary injury, from extension of thrombosis, venous infarction, cerebral edema. Anticoagulant is the main treatment, supplemented by endovascular thrombectomy in select cases. In patients with venous infarctions and hemorrhagic transformation, we may have to deal with seizures and intracranial hypertension. And in most severe cases, decompressive hemicraniectomy is necessary. Ultimately, the goal becomes preventing recurrence, and for that, we need to identify and address risk factors. Let's review all these treatments in a bit more detail. When it comes to treatment, guidelines are an excellent resource. I'm talking about the guidelines from the American Heart American Stroke Association and its European counterpart, the European Stroke Organization. Unfortunately, the American guidelines are a decade old at this point, and European guidelines have not been updated since 2017. In the acute period, both guidelines recommend anticoagulation therapy and endovascular therapy in select cases. Let's talk about anticoagulation first. Recommendation of anticoagulation is largely based on two small randomized trials. The so-called Berlin trial of intravenous unfractionated heparin and the Dutch trial of subcutaneous low molecular weight heparin, nandroparin. Both were compared to placebo in patients with cerebral venous thrombosis, and both trials were completed in the 90s. Yeah, these trials are probably older than most people watching this video. Aside from small sample sizes, it's a rare disease after all, major criticisms of the Berlin trial included delayed enrollment, average length from onset of symptoms to anticoagulant treatment 4 weeks was exceptionally long, so severely ill patients could have been excluded, and the use of unvalidated outcome measures. The outcomes were not based on the modified ranking score that is widely used in stroke trials today, and technically existed at the time these trials were conducted. Nevertheless, the Berlin trial was stopped prematurely because of efficacy. Clinical course of the heparin group became more favorable in as early as 3 days after initiation of treatment. Who'd have thunk it? I guess the group conducting the Berlin trial thunk it. Go team! The Dutch trial also generally enrolled patients who were less sick, without significantly increased intracranial pressure. Imbalance at baseline may have favored the placebo group. There were more cases with isolated intracranial hypertension in the placebo group, and more patients with venous infarcts in the nandroparin group. Certainly, patients that present with a venous stroke will do worse than those without. Sadly, the Dutch trial failed to demonstrate statistically significant superiority of low molecular weight heparin, maybe because of this baseline imbalance. What do we do now? Well, when conflicting data exists, you can always trust Cochrane meta-analysis to put the data into a statistical blender and try to produce a more definitive answer. And that they did. When it comes to death or dependency, the trend favors anticoagulation, and the guidelines continue to recommend it. Incidentally, over 40% of patients across the two trials had venous infarctions with baseline intracerebral hemorrhage. So anticoagulation for cerebral venous thrombosis is recommended despite hemorrhage. Sounds nuts, I know. But if there's one thing we know, is that venous hemorrhage does not behave like an arterial hemorrhage. Okay, hopefully I've convinced you that you should anticoagulate. But which anticoagulant is better? Unfractionated heparin or low molecular weight heparin? Several lower quality studies examined that question. To make a long story short, low molecular weight heparin was associated with decreased death or dependency and less new intracerebral hemorrhages, less progression of disease. Our patient was anticoagulated with unfractionated heparin. But despite anticoagulation, she developed progressive lethargy, disorientation, and started having periphasic errors, and paucity of speech. Things are certainly not going well. A 19-year-old woman is getting sicker and sicker. What are we gonna do? Okay, get a grip. How about repeating her imaging? She had a repeat MRI, and axial T2, DWI, and ADC are pictured. What's wrong? That's right, the thalamic edema is worsening. There is even some restriction of diffusion on DWI suggestive of ischemia. Did our patient fail anticoagulation? And what is the next treatment step? What's that? Do you want to know the patient's partial thromboplastin time to see if heparin was therapeutic? Okay, here's the graph of her PTT values. This is the lowest value of 80 seconds at which PTT was considered therapeutic in the Berlin trial. And our patient got worse here. You can see the problem, right? Our patient never reached therapeutic level. Because of large clot burden, heparin usually takes a while to become therapeutic. And this is probably the better reason to choose low molecular weight heparin, which provides a more consistent anticoagulation. Anyway, at this point, our patient is deteriorating, so we need to try thrombectomy. In the literature, who are these patients that receive thrombectomy? As you would expect, it's the patients who are sick and at risk for poor outcome. A systematic literature review summarized the characteristics nicely. Majority had thrombosis of multiple sinuses, failed therapeutic anticoagulation, had venous infarctions with pre-treatment hemorrhagic transformation, and focal neurologic deficits. Less than half had stupor and coma, presumably due to thrombosis of the deep venous system, and seizures. The reassuring finding is that 84% had good outcome post-thrombectomy. There was also a generally low incidence of major hemorrhage. Of course, by definition, this is a biased sample, so this information should be taken with a grain of salt. The only randomized controlled trial of thrombectomy for cerebral venous thrombosis was attempted nearly a decade ago, but unfortunately it was terminated prematurely for futility. 67 patients out of 164 were enrolled, and analysis of those patients showed no difference in clinical outcome between anticoagulation and endovascular treatment. The latest Society of Neurointerventional Surgery guidelines in 2018 recommend the following indications for endovascular therapy: clinical deterioration despite anticoagulation, progression of intracerebral hemorrhage and/or venous infarction, coma, deep cerebral venous thrombosis, posterior fossa involvement, presumably because of higher risk of brainstem compression, and contraindication to anticoagulation, such as thrombocytopenia and bleeding disorders. And the strategies used to remove the clot include direct aspiration, retrievable stents, infusion of tissue plasminogen activator, mechanical clot disruption, and aspiration with distal assistance devices like a balloon. I am specifically and very carefully avoiding brand names of devices. There is no data proving one approach superior to another, so multiple approaches are used today. But I digress. Let's return to our patient. Our patient underwent a thrombectomy with thrombolysis, that's infusion of TPA into the brain vessels, with successful partial recanalization of the deep venous structures. How do we prevent further deterioration? This question brings us to the final part of the talk: post-acute care and outcomes. Why are we still using rat poison? Fun fact, rat poison is vitamin K antagonist warfarin. At least that was its intended use back in the 1930s. Let's talk about our options for long-term anticoagulation. The typical strategy, based on the literature, is to start parenteral therapy, low molecular weight heparin or unfractionated heparin, early after the diagnosis of cerebral venous thrombosis. If the patient remains stable, then transition is made to oral anticoagulation. Direct oral anticoagulants are safe and effective in preventing peripheral deep venous thrombosis, but is there any evidence of their efficacy for cerebral venous thrombosis? The only randomized controlled trial that was published at this point is the RESPECT-CVT trial. RESPECT CVT. Warfarin or dabigatran was started 2 weeks after cerebral venous thrombosis diagnosis and continued until 6 months. Nearly half the patient had parenchymal lesion at presentation, so the patient population had mild to moderate disease severity. Surprisingly, over 90% of both groups did very well at 6 months. We are talking modified ranking score of 0 or 1. And none of the patients had recurrent thrombotic events. The bleeding risk was similar in the two groups. So based on this trial, dabigatran is a reasonable alternative to warfarin for long-term venous thrombosis treatment. What about using direct oral anticoagulants in that early period, within the first 2 weeks of diagnosis? The SECRET study comparing rivaroxaban to low molecular weight heparin and vitamin K antagonist is currently ongoing. I'll whisper the results when they come out later this year. Another unanswered question is the total duration of anticoagulation. Excluding patients with thrombophilia, currently most people with cerebral venous thrombosis are being treated for up to 6 months. The benefit of extending oral anticoagulation to 12 months is currently being tested. This study is part of the International Study on Cerebral Vein and Dural Sinus Thrombosis project. It's truly ambitious and seeks to recruit over 1,400 patients across nearly 100 centers in more than 20 countries. Oh, and speaking of ultimate duration of anticoagulation, finding thrombophilia can certainly change things. This systematic review and meta-analysis included over 50 studies, over 4,000 patients in total, and aimed to define the non-genetic and genetic risk factors for cerebral venous thrombosis. The study identified 19 statistically significant factors. But for the sake of clarity, let's limit the list to the top 11 risk factors that will require workup and modification. Interestingly, the top 3 risks are protein C deficiency, oral contraceptive use, and antiphospholipid syndrome, with an odds ratio of thrombosis increased up to 11 times. Okay, protein C deficiency, oral contraceptives, antiphospholipid syndrome. Got it. But let me ask you a question. What disorder strongly associated with thrombosis that is paradoxically absent from this list? Right. Where is malignancy? Interestingly, malignancy was more associated with non-cerebral venous thromboembolism, like deep venous thrombosis and pulmonary embolism. Also, considering the rather interesting time in which we live now, we should probably spend a moment on COVID-19. COVID-19 is another potential risk factor. From the limited data that's available, the incidence of cerebral venous thrombosis in COVID patients is thankfully still low, but mortality rate is certainly increased. But COVID-19 aside, thankfully the outcomes are generally favorable. Majority of thrombosed cerebral veins recanalize, mortality is very low, and most patients have excellent recovery. We're talking modified ranking scores of 0 to 1. Recurrence is very infrequent, even in cohorts at risk. But over half of the so-called fully recovered patients remain cognitively impaired. They had restrictions on reintegration into their prior life. So let's just say there's certainly an opportunity for improvement in the treatment of this disease. So what happened to our patient? Thrombophilia workup was negative. Oral contraceptives were discontinued. And she was treated with warfarin titrated to INR target of 2 to 3. This patient was managed before the publication of the RESPECT CVT trial. Imaging was repeated at 3 months. Whoa, check it out! The deep draining system is completely recanalized. It's not very surprising. Nearly 85% of recanalization is reported in the first 3 months of treatment. There was certainly resolution of thalamic edema, but gradient recalled echoes still showed residual thalamic hemorrhage. Thank you for staying alert, awake, and at least partially oriented through this talk. If you still have an ounce of attention left, let's review the 10% of this talk you should remember. You suspect cerebral venous thrombosis in patients presenting with persistent headache and risk factors, like combined oral contraceptive use, headache with symptoms of intracranial hypertension, headache with focal neurological deficits, unexplained encephalopathy, or painful ophthalmoplegia and other cranial neuropathies. Non-contrast head CT and CT venogram with contrast is a good start. Next, are there signs of elevated intracranial pressure? No, and the patient is deemed stable, start low molecular weight heparin. If there are signs of elevated intracranial pressure, start general intracranial pressure crisis management. With large hemispheric lesions with impending herniation, decompressive hemicraniectomy should be considered. No randomized controlled trial of decompressive hemicraniectomy was specifically performed in cerebral venous thrombosis. Such a trial is unlikely to be feasible and will be considered by most as unethical. But in retrospective series, the vital and functional outcomes of decompressive craniectomy in patients with cerebral venous thrombosis are much better than outcomes from similar surgery for ischemic or hemorrhagic stroke. When possible, patients should be started on parenteral anticoagulation with unfractionated heparin. IV heparin can be easily reversed in case of a surgical procedure. If the patient remains unstable, with clinical deterioration, progression of intracerebral hemorrhage and venous infarction, coma, thrombosis of the deep venous drainage, or posterior fossa involvement, endovascular therapy may be considered. And once the patient is stabilized, anticoagulation may be transitioned to low molecular weight heparin. Consider trending D-dimer to document efficiency of anticoagulation. I know I start to feel better when D-dimer trends down. Baseline brain MRI and MR venography with gadolinium should be performed at this point. Thrombophilia workup is also recommended, especially checking for protein C deficiency and antiphospholipid syndrome. If the patient remains stable and is ready to be discharged, consider switching to a direct oral anticoagulant treatment for 3 to 6 months and repeating neurological examination and MRI-MRV in 3 months. This is your topic for today. Until next time, thank you. Bye.